The following podcast is part of a certified educational activity titled Beyond Clinical Trials. Can real-world evidence provide a roadmap for long-term treatment planning in EGFR Mutation-Positive NSCLC? Data-driven guidance on patient selection, therapeutic sequencing, and tailored use of expanding options. Access the entire activity and complete the post-test at www.peerview.com/GPR. Downloadable slides and practice aids are also available.
Hello, this is Dr. Edward Kim from the Levine Cancer Institute, Atrium Health in Charlotte, North Carolina. Welcome to this on-demand educational activity focused on nuances and real-world considerations in managing patients with EGFR-positive lung cancer. Molecular testing and treatment in the landscape of lung cancer has really changed, and it's really been an evolution as well as a renaissance in the last decade of what we've had as far as options for our patients. It is very much important to remember that EGFR mutations were really the first mutations to be found, and these are the ones that have been implemented in our clinic. What we've learned over time is that one size really doesn't fit all. And we can't just call them EGFR mutations these days. There are sensitizing mutations, resistance mutations, and other ones that are relevant for practice. What's the latest evidence and what should really inform our decision making? This is what we're going to talk today, and we'll give a review of what the current landscape is and where it's all moving toward. So let's first talk about the genomic complexity and the subtypes of lung cancer and why it's important for molecular testing to occur in patients with advanced non-small cell lung cancer. If we go back to the 90s and 2000s, the debate always was, is this a non-small cell or a small cell? There were even several reports that wouldn't even report whether something was a squamous versus an adeno, and that was because it didn't really match up with our treatment paradigms. Doublet chemotherapy was utilized in most patients, regardless of whether it was an adeno or a squamous, and even in small cell we used many of these regimens. And then that finally changed in the early 2000s. We finally started getting some targeted agents into the clinic, but it was interesting because those agents weren't targeting any specific measurable target we were assessing in a patient's tumor. And then we started finding EGFR. EGFR was an important driver, we thought, in the mechanism of cancer development in lung cancer. And finally, EGFR mutations were brought out. And then as we studied these, other mutations began to show up. So it became very exciting as we progressed through the mid-2000s and now up to the teens that there are multiple mutations, driver alterations that we're finding at various different incidences. We haven't gotten them all figured out yet, but it's certainly gratifying to know that we can find subsets molecularly in lung cancer. And the importance of this lung cancer genotyping has really been highlighted by the therapies that have hit the market. We now know that instead of using EGFR drugs in any patient for lung cancer, you can identify the molecular alteration in that tumor and treat with an EGFR inhibitor. And if you get that result, you will have better shrinkage of tumor, longer survival, better progression-free survival. We've seen the same thing happen in a space like ALK, where now we measure for ALK translocations, and the same thing. We have drugs that correspond to these alterations and definitely improve survival, response, as well as quality of life in patients. So now over time, we have seen that molecular testing guidelines for lung cancer have been updated. And what's really important is that we are assessing and measuring these markers in these patients. It is really important because there are treatments available, these tyrosine kinase inhibitors, that are available for patients. And if we don't do the testing up front and wait for that testing to occur and then utilize that testing in our treatment decision-making capacity, then we are not delivering the best care for patients. And this highlights the spectrum of EGFR mutations that we see as we measure from exon 18 all the way past 22, 23, and 24. You can see how these cluster with various different areas. One of the areas that I'll point out is the orange box, which is T790M. That is a EGFR mutation, but not a sensitizing one. It is the resistance mutation that's been identified, and certainly was a very novel class, especially with a drug that was able to target T790M and help our patients. So what are the minimum testing requirements that exist for EGFR mutations? Well, you certainly want to make sure that you're testing between exon 18 and 21. This will allow you to identify sensitizing mutations in exon 19 as well as 21, and then the exon 20, which has both insertions in T790M, and also what we classify as uncommon mutations that occur between the exon 18 and 21. So to summarize, the CAP, IASLC, AMPA, and ASCO guideline recommendations, this is how it identifies. Who should you test? Well, really anyone with advanced stage lung adenocarcinoma, and even some squamouses are tested practically. You want to make sure that you have the clinical history, but again, smoking status, although you find in never smokers there's a higher percentage, you shouldn't skip not treating smokers because they also will harbor mutations, their tumors will. What should you test? Again, EGFR listed here, both in the primary or metastatic area. I think it's important to have histology and cytology, but what's really important these days is to have enough tissue and make sure you talk to your pulmonologist or interventional radiologist to make sure that enough tissue is obtained. We don't need a cytology report or a histology report with inadequate tissue. We need to make sure we're able to measure markers, and this includes EGFR, but other markers that are now FDA approved for patients with advanced lung cancer. And then when? This needs to happen up front. We do it reflexively at Levine Cancer Institute in any patient who's diagnosed in this setting. We know that they can take anywhere between 3 days and even more than 14 days to get these results. The guidelines will state that we want to keep this within 14 days, so that is sort of the quality standard of care that we want to adhere to. But we know that scheduling a biopsy, making sure there's adequate tissue, and then if you don't have a lab in-house, having to send it out can cause all kinds of delays. But it is paramount that you actually wait for the results and use the results in your treatment decisions. So now let's focus on EGFR TKIs and how we now use them up front. So we have many TKIs on the market. First started with first-generation drugs like erlotinib and gefitinib. We remember in the early 2000s when gefitinib was being tested and some of the dramatic responses that we saw. These are reversible binding drugs with decent wild-type inhibition. You have second-generation drugs, which include Afatinib and the recently approved Afatinib. Irreversible binding, they do have a larger treatment spectrum because they also hit HER2, but they also do have a narrow therapeutic window regarding T790M. And then you have the third-generation drug, osimertinib, which again is an irreversibly binding drug, doesn't really hit wild type at all, but has a very good therapeutic window with T790M. Here's a summary of different trials that look at TKIs versus combination chemotherapy. IPASS was really the one that changed our perspective, that in fact using mutations up front could differentiate between using a combination chemotherapy and a single EGFR TKI, and that's just been validated in all these subsequent studies. The most recent ones have been LUX-Lung-3 and LUX-Lung-6, where Afatinib was head-to-head against chemotherapy in a patient population that was EGFR mutation positive, and you can see the efficacy numbers aren't even close. So there really isn't any debate these days of whether if you have an EGFR mutation, you should use an EGFR TKI. There also isn't any debate that you should be testing for these folks up front, but we still see some deficiencies out there as far as folks who are testing for the mutation, but actually utilizing the mutation in their treatment. And so I'd urge you to really wait before you start treating, especially if you're testing, because we need that information to make that decision. Here's LUX-Lung-7, which you can see the efficacy values. This was Afatinib versus gefitinib head-to-head. And you can see the progression-free survival as well as the overall survival were better for the Afatinib. The most recent data that led to FDA approval was with Dacomitinib. Here is the progression-free survival for the Archer 1050 study. And again, you saw an increased benefit of PFS in the patients who received Dacomitinib. We've also seen over time that the adverse events have definitely evolved. Certainly, when we first started using TKIs compared to systemic chemotherapy, they were different types of side effects. We weren't used to dealing with rash or acne or diarrhea. We were more used to bone marrow suppression and giving growth factors or transfusions. So it was a different type of side effect that oncologists had to learn how to manage. With Afatinib, especially at the higher doses, you saw more side effects, but this was tempered by dosing. And then most recently, Dacomitinib, although a newer generation drug, has many side effects, and those have been proven challenging to manage, although Dacomitinib is a very active drug. Osimertinib is one of the more recent drugs that has been FDA approved. It was based on the FLORA study. And osimertinib is really one of the newer generation drugs that has changed the standard of care. When you look at the FLORA study, which was osimertinib versus either gefitinib or erlotinib, the benefit that occurred is very clear. What's also a nice characteristic about this drug is that it does penetrate the CNS, and there were patients who were allowed on the study with CNS metastases, and you can see the efficacy hazard ratio of 0.47 in those patients who had brain metastases, and the benefit in hazard ratio that led to the overall PFS improvement. What's been very surprising and welcoming about osimertinib is its safety profile. Those of us who have used the drug see this in practice, that there really aren't too many side effects. We've seen a lot of activity in 2018 regarding EGFR mutated non-small cell lung cancer and therapies. In September of 2018, we had Dacomitinib, a second-generation EGFR TKI, approved for first-line treatment of non-small cell lung cancer patients with sensitizing mutations, again, either being deletion 19 or L858R. In April, earlier in 2018, we had a third-generation EGFR TKI, osimertinib, that was granted an additional approval, now in first-line, for these patients with metastatic non-small cell lung cancer, and again, whose tumors harbor EGFR exon 19 or 21 mutations. And then in January of this past year, 2018, we've seen a second-generation drug, Afatinib, that was, again, approval was broadened based on data that had been around for quite some time, but now was put into standard of care, which is uncommon mutations. So now we're going to change the focus and look at acquired resistant and what we do second line, well, especially in these patients who are on EGFR TKI therapy and then their disease begins to progress. We've studied this in the past in chemotherapy. Everybody was trying to find a reason why chemotherapy resistance occurred. I don't think we found many answers. We have found resistance mechanisms in patients who have EGFR-driven tumors, and one of those was T790M. The other thing is that it's a common reason for resistance. So in those patients who are taking a first or second generation EGFR TKI, you get development of T790M. And so osimertinib had its first approval in this setting after early generation TKI upon resistance, finding a T790M mutation, and then given osimertinib. And so rather than giving chemotherapy, this has really changed the standard of care. And then here we see in AURA3, this is the phase 3 study of osimertinib versus chemotherapy. You look at progression-free survival, and again, was very good when looking at a combination of platinum pemetrexed versus osimertinib. This was clearly superior with the TKI treatment. The approvals have changed, and osimertinib is now given first line. Now we're trying to figure out what type of resistance occurs after giving osimertinib first line. And that's still being looked at. There have been some papers out there to describe C797S, but again, we don't have great treatments to target that particular mutation. There is some speculation that earlier generation drugs may actually target that as those tumors may be sensitive, but we're still trying to figure it out. Right now, what's commonly done is that chemotherapy or combination chemotherapy has been given after osimertinib treatment. Now let's take a look at some real-world utilization studies with EGFR-targeted therapies. There is a trend toward wanting more real-world data. We can see that as we get more drugs approved. Sometimes the populations that are included in these clinical trials are not really the patients that we see in clinical practice. And so we want to try and find some data that may in fact match to what we're seeing in the clinic on a daily basis, and hopefully it relates to what we're seeing in the clinical trials. There have been some investigations that have been reported with Afatinib, for instance, compared with either Gefitinib or Erlotinib. There was a Canadian study as well as a Korean study that looked at 400 to 500 patients. And again, that's been affirmed what we've seen in some of the Lux Lung studies, that head-to-head Afatinib, a newer generation drug, has performed better than Gefitinib or Erlotinib. We're also noticing that the real-world population does have brain metastases, and that there has been efficacy with Afatinib-based treatment in these patients. And certainly, as we've found uncommon EGFR mutations, that we are seeing benefits with Afatinib. And these are all consistent with how we perceive this drug to perform in our practice. There were some real-world dose reduction studies out there. Real JIDO study, which was an Afatinib dose reduction study, looked at to see if efficacy was compromised if you were decreasing the dose. What we found in the clinic, and this has been my own experience, is that if you start somebody at 40, they will have side effects. We usually then reduce them to 30 or even 20. Some folks feel uncomfortable doing that, and I remind them that in the past, when we had Erlotinib, for instance, at 150, that was a tough dose to take, and most people would dose reduce it to 100 or to 75. And so there have been a couple studies that Liang and Tanaka have published that showed that there was very good efficacy with Afatinib, regardless of the dose reductions that occurred. So you can feel comfortable doing that. I think we have been. It's always just a little bit different when there's a new drug and we're dealing with new dosing schemes. So Geotag was the first global observational study that was looking at first-line Afatinib followed by second-line osimertinib. And that's how the standard of care was for quite some time, treating patients with a first-line EGFR TKI, and then if a T790M mutation occurred, giving them osimertinib. What was done on this study was to look at medical and electronic health records. They looked at patients who were in real-world practices across the globe. Patients were identified if they had an EGFR mutation and were TKI naive with advanced non-small cell lung cancer. They were treated with Afatinib first and then developed a T790M and then received second-line osimertinib treatment. So this was a very specific population of patients that were being identified for this analysis, and the primary outcome was to measure the time on treatment. So Geotag had 204 patients across 10 countries. Those are listed here. The patients discontinued first-line Afatinib due to a variety of reasons, but mostly progressive disease. All of these patients then, again, who were found had the T790M mutation and received second-line osimertinib. And then at the time of the analysis, 106 patients had discontinued osimertinib, and mostly due to progressive disease. Here are the characteristics of the patient population that was looked at. 50% of the patients were female. About a quarter of them were Asian. Deletion 19 included almost 75% of the mutations that were identified, and then a proportion of PS 0, 1, and 2, as well as 10% of patients having brain metastases. And those are highlighted here, as you can see. So when we look at the time on treatment, that was the primary endpoint. You can see here that sequential Afatinib and osimertinib had a median time on treatment of almost 28 months, which is impressive when we're talking about two different therapies given to patients with non-small cell lung cancer. When you look at each of the subgroups, there was actually benefit in patients who were Asian, those who had deletion 19, and those who had better performance status. When you look at the Asian population, again, here's a swimmer's plot, and you can see that the time on Afatinib, as well as the treatment-free interval, and then the time on osimertinib was quite long, and the overall median time on treatment for this population was now rounding toward 50 months. Here's the curves when looking at deletion 19 versus L858R, and again, those patients who had deletion 19 positive disease did have a longer time on treatment. And then looking at the overall survival, both 2 and 2.5 year landmark analyses, again, really quite impressive testament to how personalized medicine and identifying the patients who have the appropriate markers and giving them the right disease, what it can lead to. So what are the conclusions from Geotag? Well, again, this is a retrospective study to look and see at real-world evidence. It was looked at a variety of different countries, and it showed that it's feasible when patients are taking Afatinib and getting osimertinib subsequently, who develop a T790M, that they can have very good outcomes. The median time on treatment was very large, and I think we observed that in our clinical practices. Again, quantitatively, it was more than 25 months, 27.6, and there seemed to be a better predilection of benefit in Asian patients and those with deletion 19 positive disease. And so, again, taking this as the data is, I think this certainly can warrant further study. What would be needed is a prospective study to really see in those patients who maybe are just deletion 19 positive who develop T790M, whether giving a sequenced approach is better than starting with frontline osimertinib. So now let's talk practicalities of treatment selection in advanced non-small cell lung cancer patients, and what should we do, what should we consider. So again, we have multiple drugs FDA approved, and this includes gefitinib, erlotinib, afatinib. Now we have dacomitinib as well as osimertinib. We know afatinib is the standard of care for the uncommon mutation population. Certainly, most of the guidelines will state that based on the FLORA study, osimertinib is the appropriate approach for first-line patients who have an EGFR mutation. But again, I think down the road, we can look at it prospectively and see if maybe this paradigm needs to be changed to something sequential or depending on what type of mutation appears in the patient's tumor. When you ask physicians, and this was a global survey that Dr. Wheeler presented at the recent ISLAC meeting, you can sort of see that when you survey these folks, and these were 310 oncologists who were globally based, that you want overall survival. That's really important, but also quality of life. And so balancing the two is really important, and that we need to continue to study resistance mechanisms, because all of us, especially on the practitioner side, like to have a backup plan. We don't like to tell our patient, gosh, I'm not sure what to do next. We're going to just try this as long as we can. We always want to have a backup plan, and maybe even a backup to the backup plan. So that is really how we like to have those discussions, and we want to see science and research catch up to that. So what are the top priorities? Again, we want people to live longer, but we want them to live with a longer and better quality of life. We like to max out our treatments as long as possible. The fact that you could put somebody on oral therapy for years before having to go to intravenous chemotherapy is a great thing. There are areas where we need to look closer. What do we do with patients with brain metastases? I think more and more we're seeing that we can treat these patients like anyone else who comes through the door. We may have to manage some of their symptoms locally, but they can be treated with systemic therapies, and they'll do very well compared to what we used to think. ECOG performance status is obviously a really important characteristic. I don't think we fully understand the best way to assess it or measure it. It's still a judgment call by each individual physician. Our sophistication in measuring EGFR mutations is certainly increasing. We're getting more and more data. I still remember the early reports we would get back, and it would have all of these different subtypes, and we'd be like, what is this, and what do we do for that? And I think that's starting to get clarified a little better, but research can't keep up with that right now. And so we're going to still have to see if we can treat them similarly or group them, or what we can do with that. And that'll be very relevant also in the resistance setting. And then we always know that race and ethnicity make a difference. The Asian population has a higher incidence of EGFR mutations, and maybe they do better based on some of the data that we've seen if they are treated with an EGFR TKI. So is there a role for sequencing in EGFR mutant non-small cell lung cancer patients? Well, again, I think some of the observations that we see in a study like GeoTag make us think about that. We have seen that sequencing those therapies in the real world, and that was because that was the standard of care, those patients did really well. It's tough because this is a retrospective look, and you are biasing the population that you're choosing. And so randomized prospective data would obviously be the best way to prove that that is the optimal way to treat patients. Again, deletion 19, we know that those mutations are more prevalent and they do better with Afatinib as well as with some of the other sequences. So we know that there's a difference in those outcomes versus L858R. If you study in Asian patients, it's going to be a long study because they tend to do the best. And so even in this retrospective study, the median was almost 4 years. That's a long time. And we can't neglect patient populations such as poor performance status or those who have brain metastases. That is the real world. We have to learn how to treat those patients adequately. And so, again, this type of study brings up those questions. Should there be a randomized study down the road that assesses a sequential approach versus a upfront approach? So to sort of sum up all of what we've discussed during this segment, I think what's really important is that when you see a patient with non-small cell lung cancer, you need to get this testing done. That is absolute. If you're seeing a patient with breast cancer and you're getting hormones and ER and HER2 status, this is equally important. And these days, what we test in lung cancer patients up front is EGFR mutations, ALK translocations, ROS1, BRAF, and PD-L1. It's important to remember that EGFR mutations really brought us into this precision medicine paradigm. And for years, even though we had them identified, we weren't using this information in the clinic, even though we had the drugs available. That all changed in the late 2000s, and then from 2010 on, we have been incorporating testing into our paradigm. But, you know, it's almost 2019, 2020. And so we need to absolutely make sure that we're doing this testing and using that information to help direct therapy. There are more newer generation drugs. Again, another one introduced just recently in Afatinib. So we're going to have to try and figure out how to sort through the paradigm of all these drugs and what's optimal for each patient. And what's most gratifying is that we are seeing patients who harbor these mutations in their tumors live longer and better. We all are really happy when we find an EGFR mutation in a patient's tumor. We don't try to show our excitement too much, but deep down we are very excited because that means we can treat them with an EGFR TKI, we can manage their side effects, and they're not going through the every 3-week infusions of chemotherapy and going through that aspect of it. Don't get me wrong, those technologies and treatments have gotten better as we've seen immunotherapy and other things permeate the market and into our treatment paradigms. But for those patients who have driver mutations, specifically EGFR mutations, there's no question what we need to do with those folks and how we manage them. So hopefully this has been a nice way to summarize the current data. I'm sure it will change in the coming year. That's what we like about lung cancer right now, is that we are seeing changes that are happening so quickly that really need to come to our practice in a very expedited manner. So that ends our program for today. I hope you find the activity informative and useful to your practice when managing patients with lung cancer. Thank you very much for participating.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/GPR. This activity is supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated.